Okay, so I believe that everybody must have heard the concept of FAST. What is FAST? FAST is basically focused assessment sonography for trauma. FAST. Now, what we do in FAST is that we take this curvilinear abdominal probe of almost like 1 to 5 megahertz, and we place it in four four positions. The first position that we place it is the epigastrium, where we need to check the pericardial effusion. Then the second point that we trace is the right upper quadrant, where we need to check the Morrison's pouch, the hepatorenal pouch or the Morrison's pouch, also the subdiaphragmatic space, that is between the diaphragm and the liver, whether any collection is there, and the left lobe of the liver. The third point that we need to see is the left upper quadrant. The left upper quadrant, what we check? The spleen, the splenorenal abscess, and the adjacent areas. And the last point that we used to see is the bladder, the in the suprapubic area, the bladder, the vesicle area, the paracolic gutters, both the right and the left paracolic gutters, because any type of bleeding in the abdomen will ultimately seep into the paracolic gutters. So we'll see how we see. So why do we why we do fast basically? One more thing. Why we do fast? For any traumatic injury, like any sort of trauma, almost 12% are intra-abdominal bleeds, and it's almost like 60% of young adults who are less than 40 years, they die because of intra-abdominal bleeds in cases of trauma. So what is more sensitive then is its diagnostic peritoneal lavage, DPL. But diagnostic peritoneal lavage is invasive. We need to put up a needle and check. Whereas for fast and the e-fast, you don't need to put anything. You just need to put the probe, and it has a good sensitivity of almost like 96 to the extent of 93 to 96%. So definitely a good sensitivity. So here I'm taking this probe, which is the curvilinear probe or the abdominal probe, and then the orientation. If you see the orientation, this is the marker. This is the marker. So the marker has to be on the towards the right shoulder of the patient, and there are two orientations. One is the transverse orientation, which is this. The other is the sagittal orientation, which is this. So this is the transverse orientation, this is the sagittal orientation. Now in cases of generally we start off with transverse orientation. So what we do is, at almost 30-degree we are seeing this view. So we need to see the pericardium. See, we are seeing the pericardium here. Just focus out here. If you see, you can see the pericardium out here, right? The cardiac structure is visible, and if you see very clearly, there is a thin rim of fluid that is collected in the around the heart. Okay, so there is some amount of pericardial effusion which is visible out here. Okay, and now see the angulation that I am putting it. It is almost like parallel to the skin. Then only you will get the visibility of the heart. If any sort of pericardial tamponade is there, what we see in pericardial tamponade, there is right ventricular diastolic collapse along with plethora of the inferior vena cava. So you will find right ventricular diastolic collapse along with plethora of the inferior vena cava when there is a case of pericardial tamponade. Okay, this is the view that you need to create, the first view that you need to create while doing a focus assessment sonography of trauma. Okay, now if I rotate it clockwise, I can see the this hole is the liver, and if we rotate clockwise, we can again see the pericardium. See, again the heart window has come up. So this is the heart. So show it here. So here I have come in the sagittal section. Previously it was the horizontal view. Now it is a sagittal view. Okay. So this is the view, first view that you need to create for a focus assessment sonography of trauma. Now we are going to see the right upper quadrant. Just focus it here. In the right side, what we need to do is, we need to take the probe, and the probe can be placed in three ways basically. This is the horizontal orientation, this is the vertical or the sagittal orientation. In the sagittal orientation, the marker has to point cephalic. Okay, the marker has to point cephalic and the probe has to be like this. Now the problem that arises when you are seeing this window is that there are ribs. So the ribs will create artifacts. As a result, it won't be visible. So what you have to do is you have to orient slightly obliquely so that the rib artifact is gone. Now what can you see here? What is this? This is the kidney. Just above the kidney, if you see out here, in one window you have to bring the kidney and the liver. That is the Morrison's pouch. See, we have brought the liver in the window and the kidney in the window. So this is the, and the space in between the kidney and the liver is the Morrison's pouch. So can you see it? The liver and the kidneys in one window, and if any collection is there in cases of trauma, the collection can be seen here, which is not here in this case. Then what you need to do is you need to go up and just see the liver, whether there is any injury in the liver, and go down and see in and around area. So this is the kidney. When you bring the liver, you see the Morrison's pouch. Okay, this is the right upper quadrant view, which we have seen in the sagittal section. Now the left upper quadrant view. If you see, one more thing, when you see the right upper quadrant view, the ideal position is posterior to the mid axillary line. The position has to be posterior to the mid axillary line, such as like this, in the 7th to 11th intercostal spaces. Okay, whereas when you go to the left upper quadrant, the position is slightly up. Okay, because spleen lies slightly up. So I'll show you the spleen out here. Here also you need to do the same. You need to focus on the kidney, which I have focused here, the kidneys, and then you go up slightly. In one window you need to bring the spleen and the kidneys. So can you see the spleen now here coming up? Yes. This is the spleen, this is the kidney. Can you see it? So in one window you have to bring the spleen as well as the kidneys. This is the spleen, this is the kidney, and you have to see in between whether there is any bleeding or not. So this is the left upper quadrant view of FAST. That is the focus assessment sonography for trauma. And what is the last view? The last view, what you will do, the pointer again pointing towards the right shoulder, will place the, just in the suprapubic space, will place transversely. So this is an intubated patient where the full bladder is not there. But yes, what I can see here is the Foley's catheter. See, this is the Foley's catheter. Can everyone see that? So in any case of full bladder, you can see the bladder here. Okay. So the probe position. This is the probe position that you will see horizontal. And now going to the paracolic gutters. What you will do is for paracolic gutter, you will just rotate it clockwise, bring it on the right. See here, if any collection is there. There is no collection because there is a separate category of patient, and then show it here, and then you will move the probe here. So you will just see here the bladder, then the paracolic gutters here and here. These are the paracolic gutters. When you see the bladder, if you can visualize the bladder properly, you have to go to taking a more angle, and in cases of females, what you can see is the recto-uterine pouch and the vesico-uterine pouch. In cases of males, you will see the vesical area and the retrovesical area, okay, or the rectovesical area. So just behind the bladder, you will find the rectovesical area. So these are the techniques of FAST that you do, and a new technique that has come up, not a new technique, basically an extended version of focus assessment sonography of trauma, is the lung picture. So first what we have taken is the epigastric window or the cardiac window, the right upper quadrant, the left upper quadrant, and the suprapubic area. Now what we need to do is we need to see the lungs. Again here there are two areas. You can see the apex. If you can see B lines, that means you are excluding pneumothorax. So here you can see slight bit of B lines are there. So we can exclude it. Okay, pneumothorax is not there. What happens in pneumothorax is on M mode you will find a barcode sign. I'll just try to bring it. Yes. See, these are the B lines that you can see. Long-term reflections. Yes. And we have to see the movement of the parietal and the visceral pleura. If you see here, you will see the movement of the parietal and the visceral pleura. The movement is less, but definitely it's there. If you see here, then you will see the other lung. Same, the other lung, both upper and the lower areas you have to scan in the sagittal section as well as in the transverse section. And when you see here, when you see the lungs, you have got some signs. In cases of pneumothorax, you tend to see the barcode sign, whereas in cases of yeah, see, these are the striated B lines that are coming. Okay? So in cases of normal lung, what we see is the seashore sign or the ant sign, ant hill sign. In cases of pneumothorax, you will see the barcode sign. So this we'll discuss later. Okay?